Good afternoon. This is Dr. Anju Singh, recording exercise 21, cranial nerves from the 6th edition of Allen and Harper Laboratory Manual for Anatomy and Physiology. So cranial nerves, we have 12 pairs of cranial nerves that leave the ventral surface of the brain. All right, and they are numbered in Roman numerals from anterior to posterior. All right, so looking at this figure right here, 21.1, anterior most, you have the olfactory, first cranial nerve, which is the olfactory nerve. The nerves themselves are extremely small. So if you remember looking at the skull, the cribriform plate, the nasal mucosa is literally millimeters away from the brain across the cribriform fossa. So the cranial nerves, the olfactory nerve is extremely small and therefore barely visible. So the olfactory bulb, where these nerve synapse is all that's really visible. And the olfactory tract is there. So the first cranial nerves are the olfactory nerves, which are barely visible in this figure. Second cranial nerve is the optic nerve. And then here, this is the optic chiasm where they cross over. And after the crossing, this part is known as the optic tract. So just like how you have the olfactory tract, this would be the optic tract. But the optic nerve is the part before the chiasm. So if the first cranial nerve, this is the second cranial nerve. Then comes your third cranial nerve is an oculomotor nerve. Fourth cranial nerve is the trochlear nerve. Fifth cranial nerve is the trigeminal nerve. Trigeminal means it has 3 nuclei, and as you can see here, it's kind of bulging, and it's got 3 nerves coming out of it. Its 3 divisions are ophthalmic, maxillary, and mandibular, and we'll talk about that in a little bit. Then the 6th cranial nerve is the abducent. As the name itself says, most of these nerves, the names give away what they do. Abducent nerve abducts the lateral rectus muscle of the eye. The 7th cranial nerve is your facial nerve. The 8th cranial nerve is the vestibular cochlear. The 9th cranial nerve is the glossopharyngeal. The 10th cranial nerve is the vagus. Vagus is known as the wandering nerve, and we'll talk about that in a minute, why it's called the wandering nerve. Then comes the one second, that's not how you write 10, that's 5. All right, vagus nerve is the 10th nerve. The 11th nerve is your accessory nerve. And the 12th, the last nerve, is the hypoglossal nerve. All right, so if you look anterior to posterior, as the nerves come out, that's how they've been numbered. And then what they do is how they get their name. So the textbook gives you a mnemonic, how to learn the order of these names. The mnemonic they give is, on old Olympus, towering top of friendly Viking grew vines and hops, if that helps you. All right, and then in table 21.1, they tell you the Roman numeral of the nerve, its name, and then the foramen of the cranium that these nerves come out from. And we'll get to that in a minute. This is the dissected brain itself, showing the cranial nerves, and because they are ordered literally the way they come out, this figure might as well just replace these Arabic numerals with the Roman numerals. So number 1 is the first cranial nerve, the olfactory. Number 2 is the optic nerve. Number 3 is the oculomotor nerve. Number 4 is the trochlear nerve. Number 5 is the trigeminal nerve. Number 6 is the abducent nerve. Number 7 is the facial nerve. Number 8 is the vestibular cochlear nerve. Number 9 is the glossopharyngeal. Number 10 is the vagus. Number 11 is the accessory. And number 12 is the hypoglossal. All right. Now, how do these nerves come out of the cranium? Usually, a lot of these nerves come out from a foramen that's named after the nerve that comes out of that foramen. All right. few things just to remember that are sort of exceptions is the superior orbital fissure. And I would again encourage you to go back to your axial skeleton chapter and just look at the base of the skull and identify these two foramens. Either look at the superior view of the base of the skull or the inferior view of the base of the skull and identify these foramen. So the one thing that you want to keep in mind is that the third, fourth, let's see, or let's just go in order here. So right in the beginning, anteriorly, you have axons for the olfactory foramen over here, okay, anteriormost. So what do you think comes out of here? Your olfactory nerves come in over here. All right, the second one is your location for the optic foramen, right? So the optic nerve comes in from here. The third is your superior orbital fissure. Now we have quite a few structures, quite a few nerves going in and out of the superior orbital fissure. We have your third cranial nerve, which is your oculomotor nerve. The fourth cranial nerve, which is your trochlear nerve. Only the ophthalmic division of the trigeminal nerve. So you see, so this is the third cranial nerve here. That's the fourth cranial nerve here. The trigeminal nerve has 3 branches. This is the ophthalmic branch that goes up. The maxillary and mandibular branches do not go into the superior orbital fissure. And then you have the 6th cranial nerve going in here. So you have 1, 2, 3, 4 nerves that pass through the superior orbital fissure. The third, the fourth, the first division of the 5th, and then the 6th. These are the 4 nerves that go through the superior orbital fissure. The maxillary branch of the trigeminal nerve goes through the foramen rotundum. The mandibular branch of the trigeminal nerve goes through the foramen ovale. All right, so that's your 5th cranial nerve. We covered the 6th cranial nerve. The 7th cranial nerve, which is your facial nerve, comes out of the stylomastoid foramen. So again, you see how there's an order to how these nerves are coming out of the different foramen. Just as the nerves come out of the brain, they are pretty much leaving the foramen in more or less the same order, with a slight difference here at the superior orbital fissure, and then we'll see one more little later. All right, so your facial nerve comes out from the stylomastoid foramen. Number 8, the vestibular cochlear nerve, as the name itself said, it goes to the ear, so it goes in from the internal auditory meatus. The 9th, 10th, and 11th, these 3 nerves pass through the jugular foramen. So the jugular foramen, you have your 9th, 10th, and 11th nerves passing through the jugular foramen. So the jugular foramen and the superior orbital fissure are the 2 slightly tricky ones because they have more than one nerve passing through them. But besides these 2, you have pretty much 1 foramen, 1 nerve going through, and a lot of them are named after the nerve that passes through them. All right, and your 12th cranial nerve, the hypoglossal nerve, goes through the hypoglossal canal in the base of the skull. And again, if you look at the base of the skull, all these foramen are pretty much arranged anterior to posterior. So spend a little time just knowing about the jugular foramen and the structures passing through the superior orbital fissures. The other ones should pretty much fall into place. All right, and all of this is given in table 21.1. So now we've learned the Roman numerals of the nerves, the names of the nerves, the canals through which these nerves pass in and out of the cranium. Now to get to know a little bit about the function, what do these nerves do? All right, so what do these nerves do? The textbook has given a really good acronym to remember this, mnemonic to remember this. Some say marry money, but my brother says bad business marry money. So the S stands for sensory, M stands for motor, and B stands for both, sensory and motor neurons. So what I've done is I've taken the figure which is at the end of this exercise, and superimpose some of the contents from table 2.2 here. So all these numbers in Arabic numerals 1 through 12 can just easily be replaced by Roman numerals 1 through 12. All right, so your first cranial nerve is a sensory nerve. So the S stands for sensory, M stands for motor, B stands for both sensory and motor. So S is your sensory nerve, olfactory. It is responsible for smell. Second nerve is your optic nerve, is again a sensory nerve responsible for vision. Third is a motor nerve, responsible for movement of the eyeball, also for the pupil and the lens. Now remember, pupil is not a pure motor response. Pupils can contract even in response to emotions. So we have some cranial nerves that get some parasympathetic motor fibers. All right, your third cranial nerve, 7th, 9th, and 10th have some parasympathetic motor fibers in them. The fourth cranial nerve is a motor nerve and is responsible for moving the eyeball, only the superior oblique. So if you remember the acronym LR6SO4, LR is the lateral rectus. It is one of the muscles in the eyeball. As the name suggests, it's a lateral muscle. So what it does is it abducts the eye, and therefore the nerve gets its name abducent nerve. It abducts the eyeball. And that's the only muscle this nerve supplies. SO4, again, is a motor nerve, and it supplies the superior oblique muscle. Except for these two muscles, all the other muscles of the eye are supplied by the oculomotor nerve. So one way to remember the nerves supplying all the muscles of the eye is your oculomotor nerve, third nerve, fourth nerve, and sixth nerve. All right, oculomotor, trochlea, and abducent nerve. The fifth nerve is your trigeminal. Tri means three, so it's got three parts. It's got the ophthalmic division, the maxillary, and the mandibular division. The ophthalmic division, so this nerve is a mixed nerve. It's got both sensory and motor fibers. So it's got sensory fibers from both, all the ophthalmic, maxillary, and mandibular branches, and it is also responsible for chewing. We covered the sixth nerve. Seventh nerve is the facial nerve. Again, this is both, it's a mixed nerve. It has both sensory and motor fibers, so it is responsible for taste, for facial expressions, for salivation and tears. And again, salivation and tears are emotional responses, so it has parasympathetic fibers. Eighth nerve is the vestibular cochlear nerve. It is responsible for hearing and equilibrium, so it's a pure sensory nerve. Ninth nerve is the glossopharyngeal. Glosso means the tongue, pharyngeal is the pharynx. It has, again, both sensory and motor fibers, so it is responsible for taste, for swallowing, for speech, and salivation. The fact that it is responsible for salivation means, again, it's got some parasympathetic fibers. Okay, 10th nerve is your vagus nerve. That is the wandering nerve. Wandering means it goes everywhere. All the other cranial nerves pretty much supply structures in the head and neck. They don't wander all over the body. Vagus nerve is the only exception. It wanders all over the body. So not only does it have sensory fibers for taste and other sensory fibers for the pharynx, epiglottis, which is responsible for our gag reflex and our cough reflex. Its motor fibers also help with swallowing, with speech, like the voice box. Now, vagus nerve also wanders down. It is responsible for slow heart rate, for smooth muscles in the GI, and for the digestive juices. And that's why vagus nerve also has parasympathetic fibers. All right. Coming to the 11th nerve, the accessory nerve. It is mainly a motor nerve. It is responsible for swallowing and movements of the head and shoulders because it innervates the sternocleidomastoid and the trapezius muscle. So the accessory nerve has two portions, if you will. It has the cranial portion that supplies muscles of the pharynx, larynx, and the soft palate. Therefore, it helps with swallowing. And then it has a spinal portion responsible for movement of the head and shoulders because it innervates sternocleidomastoid and the trapezius muscle. And last, this is number 12. All right. The 12th cranial nerve is a motor nerve, the hypoglossal nerve. it supplies the tongue muscles. So again, it is responsible for speech and for swallowing. All right. Now that you know what these muscles, what these nerves do and what muscles they innervate, you can quickly know how it is tested in clinics. So, for example, if you want to check for the function of an olfactory nerve, you make the patient smell some very typical smells that everyone's familiar with, you know, aromatic oils or spice or coffee or something like that. To check the second cranial nerve for vision, there's visual acuity, pupillary constriction, close vision. Is the patient able to focus on close objects? And again, for movement of the eyeball, you check for integrity of the third cranial nerve, fourth, and the sixth cranial nerve. And again, depending, if only the sixth cranial nerve is damaged, then the patient will not be able to abduct the eye, which is very, very common if patient comes in with, say, a brain tumor. So imagine if the patient has a pituitary tumor. The pituitary tumor will press on the optic nerve. So you do a visual fields test. So depending on how big the tumor is, here, let me erase this. Okay, so suppose the tumor is just a tiny tumor going from here, just small part of the pituitary tumor, and it's growing over here. What it's going to do is it's only going to damage these fibers on this part of the optic nerve. It's not going to damage fibers on the lateral half of the nerve. It's not going to damage fibers on the other side of the optic nerve. Now these fibers, they crisscross. Some fibers from this optic nerve will go over here, and these fibers will go here, and some of these fibers will cross over here, and some of these fibers will go over here. All right. So again, my point being, doing a visual field analysis can actually tell you how much of the optic nerve is damaged and how far the damage is. Okay, so that's all part of evaluating the second nerve. If a patient comes in with double vision, known as diplopia, then you check for the eye movements and figure out which muscles are impacted, whether it is the oculomotor nerve that's been damaged, or is it the SO4, the superior oblique muscle, that is damaged, which would mean that the fourth cranial nerve is damaged, or is it the sixth cranial nerve that's damaged? For example, patients who have similarly tuberculosis, they will have little tumors all over the brain. All right, and depending on where all these tumors are pressing, those specific areas will be damaged. So I've seen patients in clinic that come in just with double vision. They have no other symptom, nothing. And then when you do a head x-ray, you see these multiple tumors all over the brain. And one of those tumors is sitting on, either the oculomotor nerve or the abductor nerve. And that's how we diagnose these patients. All right, trigeminal nerve, you look for, again, it has sensory fibers to the ophthalmic division has sensory fibers to the cornea, so you can touch the cornea with a little wisp of cotton and see if the patient has the quick blink reflex. Ask the patient to bite down on the tongue depressor and see if the muscles for chewing are intact or not. For the seventh cranial nerve, it's again a mixed nerve, supplies the muscles of the face. So ask the patient to smile. A patient who has the facial nerve palsy will have a lopsided smile. Diabetic patients very often have facial nerve palsy, and facial nerve palsy can be of two types: upper motor neuron, lower motor neuron, and we won't get into the details of that. But if the patient has a lopsided smile, the angle of one side of the mouth is drooping, there's saliva drooling from one side of the mouth, these are all signs of facial nerve palsy. That patient may not be able to close one eye tightly, is not able to blow or whistle. So any weakness of the facial nerve indicate facial nerve palsy. And also taste. Taste senses can be checked to see for integrity of these cranial nerves. The eighth cranial nerve, check for hearing. Again, there are several hearing tests that are done. Putting a tuning fork in front of the ear, putting a tuning fork on the stylomastoid process can help distinguish between nerve palsy and there are two different kinds of deafness. So to know whether the deafness is because of a lesion primarily in the ear, in the cochlea, or whether it is a nerve palsy, something after the auditory nerve leaves the ear. So there are different tests to identify that. Moving on again to the nerves 9 and 10, look for taste of smell, the ability to, to say ah and look if the uvula is located in the midline, because it could be deviated if one nerve is damaged. Look for gag reflex, cough reflex. So if the patient opens their mouth and you touch the back of the mouth with a tongue depressor or a cotton, like a Q-tip or something, the patient should immediately gag or cough, showing that these nerves are intact. Again, checking for taste is another way to look for intact 9th and 10th nerves. 11th nerve, because it supplies the sternocleidomastoid and the trapezius muscle, the patient can be asked to shrug their shoulders up against resistance. An inability to shrug their shoulders up against resistance is a sign of damage to the 11th cranial nerve. And the 12th cranial nerve, again, the patient is asked to stick out or retract their tongue. The tongue should be in midline, but if the tongue is deviated to one side, it shows damage to the 12th cranial nerve. So this is all from table 2.3. So if you're able to just integrate all, just know all the names of the nerves, what they do, what they supply, and then how they test. So for example, you could see one or two questions. Patient is unable to look laterally, or the eyeball is deviated medially. What nerve do you think is damaged? Or the patient's mouth is drooling on one side, or is not able to close the eyes tightly on one side. What nerve do you think is damaged? So some basic questions like that. Again, I encourage you to do the exercise at the end of this chapter, because I use these to develop my exam questions. If you're able to do this and answer all these questions at the back, you are good, set for the exam. And that's it. Thank you.